Welcome to UMTRC, Upper Midwest Telehealth Resources. Today we're going to be discussing the culture of telehealth medicine, and our speaker is going to be Becky Sanders. Becky?
Thank you so much, Autumn. So welcome today. As Autumn said, we're going to be talking about the culture of telemedicine today, and a little bit how delivering care virtually is different from delivering care in person. So the Upper Midwest Telehealth Resource Center, or the UMTRC, covers 4 states. These states here in lilac on the map of the United States: Illinois, Indiana, Michigan, and Ohio. As you can see, there are 12 different regions around the United States, and they're colored appropriately. 2 states are shaded. Utah is shared by the Northwest Regional Telehealth Resource Center and the Southwest Telehealth Resource Center. And then New Jersey is shared by the New England Telehealth Resource Center and the Mid-Atlantic Telehealth Resource Center. We also have 2 national telehealth resource centers. CCHP is our Center for Connected Health Policy out of Sacramento, California. And TTAC is out of Anchorage, Alaska, and they are our technology telehealth resource center. So I'll be referring to them a little bit today as well. We do have a national website. So the 14 of us are all federally funded through HRSA under HHS and under the Federal Office of Rural Health Policy and the Office for Advancement of Telehealth. We formed our national consortium several years ago. We do have a national website, and that there are monthly webinars that happen with that, and they have a monthly newsletter, and there's many resources on that national website, and then you can link to all 14 of the individual TRCs from that one website. So my 30-second elevator speech when someone asks me, what do you do for a living, is I tell them I'm a virtual librarian. As a telehealth resource center, we collate a lot of resources. We do a lot of research, and it's kind of like being a detective, you know, finding out best practices and how things can best be done. We do a lot of connections with other programs, and we answer a lot of billing questions as well. So today we'll do our presentation. We're not going to talk about billing and coding today, but we are archiving all of our webinars, especially with the tsunami of interest in telehealth right now. And we found that's been a good way to get our story out and highlight our resources. So when you get the link from Autumn to find today's recording, you'll also see other recordings that we've done over the past month or so, as well as the slide decks for each of those. All right, there are many ways that you can reach out to the Upper Midwest Telehealth Resource Center. You can get to us through our website, umtrc.org, and join our mailing list. We send out a newsletter every month, usually at the beginning of the month. We also have a LinkedIn page and a Facebook page that you can follow us. So I get a lot of questions about telehealth versus telemedicine. The definitions that are out there, telehealth is the overarching umbrella for anything that is technology helping to deliver healthcare. It could be education, it could be remote patient monitoring, chronic care management, all of these things. And then telemedicine is that actual billable clinical service. So 2 types of telemedicine, synchronous and asynchronous. So asynchronous is happens one way. So a good example is dermatology, where you take a picture of a rash or a cut, and you send it off to be analyzed and then come back with recommendations. Synchronous is kind of like what we're doing now. It's a live and interactive connection between a patient and a provider. Telehealth is not a service in and of itself. There's all kinds of ologies: cardiology, dermatology, radiology. Telehealth is merely the modality, the delivery mechanism, how healthcare services can be delivered when the patient and provider are not in the same physical location. With the advent of COVID-19, we have stood up another section on our website that is specific to COVID-19 resources. There are both state-specific and national resources, so all 4 of our states are listed, and then we also have links for Medicare for all the stuff coming out of CMS. With the coronavirus and the public health emergency that's going on, there has been a relaxation in HIPAA rules. So you will not be dinged for using a non-HIPAA compliant software or video conferencing platform to deliver healthcare services. And the way that that's been defined by CMS is that you have to deliver services via a telecommunications system. So a multimedia communications equipment, including at a minimum audio and video, permitting two-way, real-time, interactive communication between the patient and the provider in order to be billed via telemedicine. Each state that we cover in the UMTRC has made similar recommendations through their state Medicaid programs. I've captured the highlights here. So they are all, some do allow telephone in their waiver for what can happen right now for billing via telemedicine, and some do not. Indiana does allow telephonic, but not text or email. What you see that is similar between these 4 things is allowance for video, one-on-one video conferencing, such as FaceTime or Facebook Messenger video chat, Google Hangouts, or Skype, or other types of video conferencing platforms. But you should not be using public-facing applications for delivery of healthcare like Facebook Live, Twitch, TikTok, or something like that. All right, I mentioned earlier the TTAC, the National Technology Resource Center, and they've got a bunch of toolkits on their website, which are great and help you and guide you information on what kind of technology is out there. As a federally funded program, we can't say XYZ is the best vendor, go buy something from them. We have to be vendor agnostic, so we do a lot of assessments, or TTAC does a lot of assessments and says, you know, here's some pros and cons about a bunch of platforms. And then it's up to you to do your due diligence. So while right now you don't need to worry about HIPAA, our guidance is still that you should use a HIPAA compliant platform, because we believe you will enjoy using that. Your patients will enjoy that ability to see their provider remotely, and that there will be something that you continue to keep in your toolkit, in your toolbox of delivery methodologies once we have gotten through this public health emergency. So this is just an example of all the different things that TTAC has on their website. If you are a part of a larger organization, you might already have Epic or Cerner or Meditech as your electronic health record. I know for sure Epic has a video platform built into it. You may or may not, your organization may or may not have purchased that module. Also there's many healthcare organizations that have chosen either Cisco or Microsoft as kind of their IT platform for everything that they do. So there are options there for video conferencing as well. So when you think about starting to see patients via telemedicine, check with your IT departments, see if they've got an existing platform that you could use for that. So we're going to spend most of our time today talking about how to develop a telemedicine program. I recognize that right now we're in the thick of things and you're trying to do your best to take care of your patients while still maintaining social distancing rules. So this is something that we developed prior to COVID-19, but even if you compress it and do it very quickly right now, and then go back and take a look at it in 6 months, and go back and see, you know, what things you can tweak to do better, to better meet the needs of your patients. So there's really 3 steps. You're going to assess and define what it is that you need to do. You're going to develop and plan. We're going to talk a little bit about work plans, and then implement and monitor. So once you implement a program, you always need to monitor it for outcomes and then tweak it to make it better based on what you see in your outcomes. So it's typically a plan, do, check, act version of managing the program. And I like to talk about this book. I read this book in the 1990s, and it was very popular at the time as far as management theories and working within workplaces. But this book is about 4 characters, and their names are Hem, Haw, Sniff, and Scurry. So this diagram here is mapping Hem, Haw, Sniff, and Scurry around the 4 PSUI forces for organizational physics. It's another book by Les Skinny. And I really like this because as you look at this and you think about these quadrants, Hem up here likes a slower pace and a structured approach, and Sniffs are innovator. They think long-term, but they're very results-oriented. Ha is our unifier, very process-oriented, but doesn't really care for a structured approach. They like an unstructured approach. And then you've got Scurry, who wants to get it done right now and very short term. And so as you think about the people that you work with, when you develop a telemedicine program, you want to make sure that you're including a broad team in your program. So you have to have your physicians, your providers, your nursing staff, your IT staff. You have to have HR involved, you have to have finance involved, and you have to have buy-in from everyone that's going to touch the program. So there are different things that motivate different types of personalities, and it might be challenging to get everybody on the same team to say, yes, we're going to go forward and we're going to do this. So here's more about the stabilizer, producer, unifier, and innovator, and the link to the book by Lex Sisney. All right, so we're going to assess and define our problem, and then we're going to develop our plan, and then we're going to implement and monitor our plan. So back to the plan, do, check, act. So to assess and define our program, we need to assess our needs and the environment. So right now we're in unprecedented times, and our environment is strange. We don't normally have the pressures that we have today. So you still probably are going to need to find a telehealth champion, someone in your organization that says, yeah, let's go ahead, let's do this, and have that corporate willingness to be able to continue taking care of patients for normal checkups and those types of things, even with the social distancing rules that are in place. You're going to have to identify and prioritize what services can be delivered via telehealth. Obviously, you're not going to do surgery remotely, but a lot of, especially primary care visits, can be done if labs need to be drawn, that type of thing. You can send a person to the appropriate lab in your local area to do those. And we're going to talk about vitals too. That's a bit of a challenge. You're going to have to rely on the patient, especially right now if the patient's at home. I mean, some of the waivers we've seen, that the biggest thing is allowing that patient to be at home. So if a patient at home has a blood pressure cuff, a thermometer, maybe they have a scale, a fitness device that they can tell you their blood pressure. You're going to have to rely on them and make the appropriate documentation that you receive that vital information from the patient. And there's going to be assumptions and constraints built into your program. That's part of it. So really, when we talk about starting a telemedicine program, what we're really talking about is changing the culture of the way that you deliver healthcare services. And you might be familiar with Lean Six Sigma. And both programs are very similar, but what they're all about is improving efficiencies and making sure that you are operating as lean and clean as possible. So you're going to eliminate wastes. And I like this picture. I attended a conference several years ago down in Louisville, Kentucky, and they had solar trash cans. And I thought, what a great use of solar power to help compost the trash. So I thought it was neat. All right, so we're going to develop and plan our specific program model. So where are the patients? Right now, mostly they're at home. And what services can we provide to meet those needs? And then what technology do we need to do that? And how are we going to organize it? What's our best organizational model within our current structure? Do we need to get HR involved or facility resources for equipment? What providers are going to provide the service? Sometimes, especially when we deal with psychology or behavioral health, we have to contract with an outside party or an outside vendor to provide those services because we don't have those providers in-house. Legal or regulatory constraints. Anyone providing telemedicine needs to be licensed in the state where the patient's physically at during the visit. So if you're in a border area, you're in Richmond, Indiana, right on the border to Ohio, or you're in Chicago, Illinois, but you've got patients that travel over the border from Indiana, those types of things. You need to make sure that all your I's are dotted and your T's are crossed for legal and licensing and credentialing. And then how are you going to implement? How are you going to let your patients know? Are you going to start with a certain population of patients? Are you going to start with Medicare patients, Medicaid patients? Do you want a phased or a pilot approach? All of these things need to be taken into consideration. One of the things that I learned when I went through the lean courses is about the 5 whys, and you really kind of got to ask yourself about that. So you have a problem and you try and ask why until you get down to the root of the reason that there is a problem. Well, I ran a red light. Well, why did I run a red light? Well, because I was in a hurry. I was late for work. Well, why were you running late? I woke up late. Well, why did you wake up late? Well, my alarm clock broke. Why did your alarm clock break? Well, I didn't know if it worked or not, and I didn't check it before I went to sleep. Why did you not check it? I just forgot to do it last night. So building upon, okay, so you forgot to do it last night, so plan ahead. That solves this particular problem. All right, so a business case, and it's pretty easy right now to develop a business case for telemedicine with the coronavirus and a public health emergency that's going on. But if you wanted to do some homework and look into it a little bit more, every 3 years, hospitals need to do a community health needs assessment or a China report. That's usually available on their website. And you can find different areas of need within that you can address via telemedicine. Again, you might need some startup costs. You might need to purchase some equipment. You're definitely going to need a platform for video conferencing. Even if you start right now using FaceTime or Google Hangouts or Skype or some type of a free program, know that eventually those HIPAA rules are going to come back into play, and you want to make sure that in long term, you make sure you've got a HIPAA compliant video conferencing program. Your payer mix, for the 4 states that we cover, the reimbursement is the same as in-person care, so you don't need to worry about that, but you will need to worry about your payer mix. We answer a lot of questions about billing and policy. The way that you bill Medicare may be different than the way that you bill Medicaid or a private payer. And is the project sustainable? You need to build in your costs for running the program and to figure that out. And then you can track program savings, scheduling. Most of the easiest things to track are miles saved by the patient or by the provider. And then you can look at labs or ancillary costs if the patient didn't drive into an urban facility and then get labs taken at the urban facility, then you can have the labs drawn or the x-rays taken at your local healthcare facility. And then you can also track, based on miles, you can track the carbon dioxide footprint. So back to hem, haw, sniff, and scurry. This is just a snapshot from this particular book. And it goes through and it says, who moved my cheese? And I moved my cheese, because change is scary. We adapt more to change when it's our own idea to make the changes. Just some things. So change your game to your design, and you're not affected by the changes of others. All right, so let's talk about our work plan. You need to identify who's going to be your team leader and your cheerleader, your champion for your telemedicine program, and then who are going to be the team members, and then what are their specific roles and responsibilities. Marketing and communication is going to be a big part of this. You're going to need to make sure, if it's a newspaper ad or a TV commercial or direct mail, social media, you need to have a plan in place for how you're going to let your patients know about this new service. How are you going to handle scheduling? Making sure that the providers know, hey, this is a telemedicine visit as opposed to, go into the clinical room and the patient's there. So you may need to update some of your policies and procedures, and you don't need a whole new set of policies and procedures. You're doing the same clinical care, you're just doing it in a different methodology. So you may need some training for staff, some process improvement and equipment training, so that they know what their roles and responsibilities are with whatever platform you decide to use. Along with your work plan, we're going to talk a little bit about the clinical space. If the provider is indeed in a clinical space, right now the provider may be at home and the patient may be at home. So you've got to be creative and do the best that you can with what you've got. What your foundation is going to be the broadband access and your software platform. So you've got to make sure that you as the provider and the patient have adequate broadband to meet the needs of whatever platform that you choose. Support, you need to make sure that the internet access, and this is more geared for a clinical institution. You can get what they call an SLA, or a service level agreement, for 2 hours or for 4 hours for outages, to make sure that your internet doesn't go down. If both the provider and the patient are in residential homes, that's usually not something that you have to deal with usually. So there may not be options for service level agreements, or they may be too cost prohibitive. Same thing with software and hardware. And then interoperability and scalability. I talked a little bit about Epic having their internal video conferencing module. So EMR integration, how are you, when you visit with the patient and you document that visit, how then does that information get back into your EHR? And it's going to depend. There's so many variabilities, we can't really get into that today. And then organizational approval. So just for budgetary purposes and procurement, you're going to need approval within your organization. And then outcomes. What kind of goals do you want to put forward for your program? You need to have goals, objectives, and outcomes. They're all going to be part of your work plan. And then you're going to need to try and make your best guess on volumes and utilization by patients, so that you can measure, track, and achieve those goals. If your goal is 5 patients a week, then that's fine. You start with a lower goal and then increase it as time goes on. But you can't meet a goal unless you've set it out for yourself. So, and then you can't also, if you don't have that goal, you can't know whether you meet it or not, and then you can't, that impacts your tracking data methodology, because at some point the CFO is going to come back and say, okay, well, did we make a profit on this or not? Is this financially stable? What's the sustainability of this? And that allows you to course correct and make changes and implement those changes within the program. And so in order to have improvements to your program, you're going to have to define those, define how you're going to do them, and plan and implement those, and test and then manage once you've implemented those particular programs. So here is our sample work plan, and some of the things that I've been talking about in your goals and outcomes is having SMART goals. So SMART stands for specific, measurable, achievable, relevant, and timely. If you don't have a SMART goal, then you never know if you've reached it or not. It's like saying, okay, I want to lose 10 pounds. Okay, fine. You're going to try and lose 10 pounds, but how are you going to do that? You have to have a time frame. You have to have certain steps to meet those goals. So same thing here. So what do you really want to do? What do you want to accomplish with this telemedicine program? How are you going to get there? What steps or activities are you going to take? And who's going to do it? Who's going to be responsible for doing that? How long will it take? And then how do you know if you've achieved that goal? So we like to use behavioral health because that's one of the easiest. It's just a conversation. You know, there's no blood pressure, there's no vitals, those types of things. So it's the easiest telemedicine service to implement because you just need the video conferencing platform. So our goal here in this example is to reduce emergency department wait times for psych consultants or for psych consults. And so what we're going to do is we're going to provide telepsych services in the emergency department. Well, what do we need to do in order to provide that? Well, we need to find a space. It needs to have privacy. Needs to not be in a noisy hallway environment. We're going to invest in some video conferencing technology, and we're going to hire a psychiatrist if we don't want to have one in-house. So whose responsibility is it for each thing? Well, the team lead is going to find the best place for that to happen, for the patient to be during the visit. Team member A is going to research the video conferencing platform, and team member B is going to figure out how to find a provider to make the service happen. And then how long will it take? You know, maybe you give yourselves 90 days. Now, I know in today's environment, you don't have the luxury of a lot of time, but you know, this is just an example. So by the end of, that should be third quarter, 2020, we'll see 20 patients via telepsych. All right, I've been doing a lot of talking. I want to stop and take some questions before we move into the next section. So as we said in the beginning, if you would please use the question and answer, the Q&A icon to ask your questions. We'll see if we can answer some questions now. So by using the Q&A, if there's any questions that we don't get to, then we can follow up afterwards with that and put out a Q&A document that allows us to track them. Well, I'm not, oh, here we go. Do you know if social work is billable? It depends. If you're talking about which provider you're going to bill. So Stephanie, if you would send me an email, my email will be out at the end. And Autumn, would you put both of our emails in the chat? We'll need to know more about the type of clinical, if it's a licensed clinical social worker, or what level of education the provider has in social work, in order to answer that question. And then also, if you're billing Medicare or Medicaid or private payer, in what state. A little bit telemedicine and Medicaid patients, specific challenges, billing and coverage, or other challenges that come to mind. So right now, it's the wild open west. All the states that we cover in our 4 states, the governors have been, and the Medicaid programs have really bent over backwards to reduce any barriers and allowing telemedicine to happen over basically any non-public facing platform. We do have links on our website to the different Medicaid programs. You'll need to follow those rules in conjunction with the COVID waivers that have happened. We haven't had enough time yet to integrate all of the COVID waivers and practices into our normal 4-state guide, but those are available on our resource pages on our website. I would say the biggest challenge that the Medicare, Medicaid has not addressed, and the FCC is trying to address, is broadband access in rural residential areas. Let's see. What's the best method to getting patients registered for their appointments when you're not scheduling same-day appointments? We have a phone room separate from the front office, and patients aren't answering their phones on the day of their appointments, but will answer when providers call. Well, that's interesting. I don't know, maybe try texting or texting the patient before the visit to make sure that they know. That's going to depend. That's an interesting one. It's going to depend on if the patient's got a smartphone, if they've got good cell access wherever they're at. Maybe it's some type of online portal to deliver the services. That might be, Courtney, that might be one that we want to follow up with, because there's so many variables depending on the size of your organization and that type of thing. All right, let's go ahead and move forward here. So let's talk about implementation. So once you're ready to start your program, 3, 2, 1, go. So you've got your communication plan and it's in action. You're going to identify and mitigate risks if necessary, because nothing's ever going to go perfectly the first time around. And identify and manage program modifications. So who's going to be in charge of monitoring? So somehow you need to be tracking all of this data. When your patients and providers are having telemedicine visits, someone's going to be in charge of tracking that. So you got to have a tracking tool in place. It could be a simple spreadsheet. It could be a SurveyMonkey survey. There's all kinds of ways to track things. But if you don't track it, you don't know if you met your goals and you don't know if there was a problem. So surveys. And it all goes back to that plan, do, check, act. So this is a quote, happens to be from that book that we've been talking about today, Who Moved My Cheese? And I really like this, especially now under the current public health emergency, but in healthcare and in life. Change happens. They keep moving the cheese. Anticipate change. Get ready for the cheese to move. Monitor change. Smell the cheese often so you know when it's getting old. Adapt to change quickly. The quicker you let go of the old cheese, the sooner you can enjoy the new cheese. Change. Move with the cheese. Enjoy change. Savor the adventure and enjoy the taste of the new cheese. But be ready to change quickly and enjoy it again. They keep moving the cheese. So I think that's very true in our environment today. So implementation is not as easy as it sounds. You've got to develop some change management theories and with your work plan. We're going to talk a little bit about a telemedicine room setup and some of the other things that I alluded to. This is kind of the good, the bad, and the ugly. And normally, we've developed this, used this particular training today that before COVID. So I've tried to update it a little bit, but keep in mind the long term as well. So normally you're talking about putting a patient into a primary care office or typical clinical office space. And you need to worry about lighting and wall color and acoustics, that kind of thing. Right now, all of the patients are at home. So this may not apply at all for today, but it may apply in 90 days or 6 months. So think about that existing patient room, and you want to make sure that there's good audio, and a lot of that falls back on technology, what technology is available to your patient, but you don't necessarily want that patient to be in a really loud, noisy environment. If they're home with their children right now and you're seeing them from home, you need to ask them to try and have someone else in the house to occupy the children while you do this so that you're not interrupted. Windows can create glare. Here in my home office, I've got this is a physical 8x8 banner behind me so that you can't see any clutter in my office. I do have a window over here. I've closed my blinds. I purchased just a basic craft light that has daylight light there that I have to front light me, and I have turned off. I do not have my overhead light on because that will create shadows. And I've also got my door closed. There's no one else in the room with me so that I'm not distracted while we're doing this today. The room size doesn't have to be big. It really just depends on what type of service is being provided. Because we talked a little bit about telehealth versus telemedicine. If you're doing education for a group therapy or diabetes self-management, then you might have a bunch of patients in the same room. So you would need a larger room. So there's all kinds of options and variables. So back to our existing patient room, you need enough room around the patient to move around and be comfortable. You might need patient vitals, you might not, depending on what kind of service is being provided. So really, when assuming right now that your patient's going to be at home and being seen from home, your providers need to worry a little bit about, they need to worry about the privacy of the patient, make sure that they're in a secure environment, that they're not, out at a restaurant, out in a parking lot with a lot of people around. Website manner for your providers. I always go back to behavioral health because it's so easy to talk about that. If you're talking about a stressful situation with a patient, the provider's not going to be able to say, here's a box of tissues, but might start the visit with, I know we're going to be talking about some sensitive topics today. Do you have any tissues available to you? You might want to bring those and have those ready if we need them. Website manner involves things like, okay, I'm the provider and I'm taking notes on my patient. So I'm going on here and I'm taking notes on my patient. What do you guys see? You see the side of my head. Is that good engagement with the provider? Does that provide comfort to the patient? No, because they think they're being ignored unless you say, hey, okay, hang on a second. I got to make some notes, and I'm going to make some notes, and then I'm going to come back and I'm going to look at you again. So as I'm going through today's presentation, what I'm really trying to do is focus on this little camera in front of me, which is kind of awkward, but I've also got my self view right underneath that camera eye. So I can look at myself as I'm talking to you and have a pretty close facsimile to actually looking directly at the eye of the camera. So those are kind of video etiquette things. I've talked about lighting here in my office, consent forms. So each state, and we did do, Luke Wortley did an awesome job on consent and documentation on one of our virtual office calls earlier this month. So you can check that out with our archived webinars on our website. Each state does have rules about consent within the state law and within their Medicaid programs. It talks about consent and documentation. And I've already talked about vital signs. That's one of the things that we're struggling with. Now I've seen some, and we haven't posted anything on the website yet, but I've seen some new documentation starting to come through kind of for physical therapy and that kind of thing, that if a patient has trouble, and it's kind of to assess muscle tone, that kind of thing. If a patient has trouble standing up or sitting down, that you can use that as a provider as a guideline to tell you about the muscle tone of a patient when you're not able to physically be in the same room and palpate. And we do have a question, since we're talking about documentation. This is about DoxyMe. A documentation verbiage, do they need a wording that visits were done in a certain products like DoxyMe or recommendations on documentation? Ludi, I would go back to the state Medicaid guidance and check out the virtual office hours that Luke did, because he referenced all of those. for documentation in your state laws. I don't think they need to know the type of program, whether it was DoxyMe or, you know, something like that. I don't think that level of detail needs to be in the record, but just that it was performed via telemedicine and maybe where the patient was and where the provider was, that type of thing. All right. And then where's the clinician during this visit? Same kind of thing. The clinician could be in a clinical setting. They could be at home. You know, do they need, if you're talking about diabetes self-management, do they need little plastic pieces of fruit to talk about portion sizes? Do they need a plate? There again, normally when that service is delivered in person, the diabetes educator has certain tools with them. Is it feasible to send plastic fruit out to every single diabetes patient that you're educating? Maybe not. So maybe you need to use the things like, you know, my thumb is a tablespoon, or the palm of my hand is 4 ounces for a serving of meat. You're going to have to be creative if you don't have those tools available to for the patient to have with them when you're working through those conversations. If I was doing a lot of education, maybe I'd hang a whiteboard on my wall and talk through that with the patient. Also I don't use it too often, but I can annotate. So you could have a whiteboard. In most video conferencing products have sharing of documents, that kind of thing, but I can draw. Let's see, what do I want to draw? I'm going to draw some squiggly lines. So I can draw over this. I'm a horrible drawer, but you know, I could draw if I'm doing telegenetics. You know, maybe I'm drawing family trees and talking about you know, those types of things, and I have to draw that out for my patient to figure out their genealogy. There's all kinds of options. You just have to be a little creative in how you decide to do that. I'm gonna need to get rid of these. Let's see. Back, and I want to clear. Okay. So some examples, and I talked about this already, but just to bring this back into mind, this is a really bad example of a provider and a patient. And it's bad because in order for the patient and the provider to be eye to eye, the provider has to turn their head. So that could be arranged better. You want a clean and uncluttered view between the patient and the provider. So that means setting up your video conferencing equipment so that the provider is able to look directly into the lens of the camera, and the patient also is looking directly into the view of the camera. So here's some examples, some bad and some good, of not looking into the camera. So here's a much better one. That person is much more engaged when they're looking directly into the camera. I've talked a little bit about light and shadows already today. So you want to front light the patient whenever possible and avoid backlighting because it just puts you into shadow. Directional lighting can also be a challenge. That's why I've got my blinds closed. If I open my blinds, I would wash out this side of my face and this side would be in shadow, similar to the picture here. So diffuse lighting can create more even lighting across the person's face. And here's some examples of being backlit. She's really in shadow there, and front lit is much easier to see the facial expressions on her face. Supplemental lighting. This one doesn't look too bad there, but if it's lit properly, you can see the skin tone of the patient is much different. So for dermatology, this is very important. And wall color. The wall color behind you can make an impact on being able to see facial changes. So these are things not to do. I had a little fun one day, and I put all kinds of clutter in my space. And so don't do this. Don't be wearing casual clothing. Don't avoid coughing and sneezing. I mean, if you're not healthy, you as a provider, you don't want to be delivering services. Looking down or away from the patient, and then here you can see with my blinds open how that washes out my face. So again, you want that clean and uncluttered view between the patient and the provider. Acoustics, I haven't talked about that too much, but in a clinical setting, often there's high ceilings and linoleum on floors. Those can create echoes. So you can do things like there's special paint to absorb sound. You could get ceiling tiles or wall tiles to absorb sound. You can move the patient, the clinician, away from noisy HVAC sounds or from traffic outside. You wouldn't want the patient or the clinician to be in a room right by the stairwell where the door is slamming all the time, or right by the elevator where people are congregating. You can use carpet and drapes to help absorb sound. Wall colors, ideal wall colors are lighter colors that work well with multiple skin tones. So you can see light blues and light grays there. And then as we're wrapping up today, just a reminder that you can connect with us in many ways through our website. We have you can email us at info@umtrc.org. You can also reach out to us through LinkedIn or through Facebook. Autumn has put in our email addresses, links to where the webinars are archived on our site. What additional questions do we have today? And there's my email address. Again, I want to reiterate, we are recording today's session. We'll have the recording archived on our website and on our YouTube page within a couple of days. We'll also have the version of the slides in a PDF format available on our website in a couple of days as well. Protocols to train staff delivering services in their homes. You know, that's such a new area. Until the last 30 days, I am not aware, but I can certainly check to see if there's protocols that I'm not aware of. Consulting at the moment, it has started to slow down just a little bit. Send me an email and we can talk and see what the scope is. We'll see what we can do. All right, any other questions? Well, thank you for joining us today. I hope this was helpful, and have a great rest of your day.